breaks the ammonia into ammonium, that is negative positively charged, and this increases the pH nearby the H. pylori to almost 6 to 7, and this is the most important way how the H. pylori survive in this strong acidic milieu of the stomach. There are a lot of other genes also involved for the survival of H. pylori, but the main important function is the urease enzyme. These are a lot of other etiologies by which the H. pylori causes the loss of secretions of the parietal cells and hereby increases the pH of the stomach. It is a disease of lower socioeconomic classes, so it will be more common in the overcrowded people, fecal route transmission, crowding, and in low socioeconomic condition, the people who are overcrowded and having less access to clean water. So it would be more common in these type of people. As we advances, it is less common in the developed country compared to the developing country. And transmission is by fecal-oral route. This is the flagellate bacteria, and how it causes the disease. It is the particular structure of the bacteria, the enzyme, especially the urease enzyme, which it produces, and it increases the pH nearby it, and the host factors like the durations of infectivity, whether it is acute infections or it is a chronic H. pylori infections, whether it is located in the gastric part or the fundus part or in the duodenal part. Accordingly, the disease manifestations are different, and it is common. It's not very common in everybody, so there has to be some genetic hits also, which requires, and it is seen in some familial disease also. Maybe some HLA positivity may be there in some part of the patients. So some genetics are also involved in the host factor, and what these both will cause, this will cause chronic gastritis. Initially it will cause acute gastritis, and then it will act as a commensal. It will not harm the body, so the body will not try to kill the organisms like the hepatitis virus. So this will be there in the gastric mucosa, and in the long term it will cause chronic gastritis, peptic ulcer disease, gastric mark lymphoma, or gastric malignancy, according to the duration and severity of the disease. This is the cell wall, and this will cause how these H. pylori causes lot of diseases by the inflammatory cells like TNF alpha interleukins. They will cause the damage of B cells by lot of cytokines, and these are the ways in which it will cause chronic infection in particular person. If we see, it is a very common disease. If we do our urea breath test, we may be positive for this particular agent. So, if it enters by the orophycal route, it enters when we eat a contaminated food, water, and initially it will cause acute H. pylori infection, like typhoid also, like any other disease. It will initially cause acute infections, and then if not treated by the body immune system, it will go into a chronic phase. And in chronic phase, it may cause enteral gastritis, and if enteral gastritis, then it will cause the duodenal ulcer. It will cause non-atrophic gastritis, and if it is non-atrophic gastritis, it may not be manifested for long term, and that is known as asymptomatic H. pylori infection. It may cause chronic atrophic gastritis, gastric ulcer, and chronic irritations of the H. pylori may cause intestinal metaplasia, that is the dysplasia, marked lymphoma, or the gastric cancer according to the duration of the disease and the advancement of the age. And with these all part, the acidity production usually decreases concurrently. NSAID, the second most common cause of ischemia ulcer is the NSAID intake. Either it may be taken for any pain, it may be taken as a aspirin for the prevention of cardiovascular or serious neurological disease, in which we take the drug for prolonged time. So if a drug is taken for prolonged time, the chances that it may cause ischemia of the gastric mucosa is more. And we know that NSAID causes the ulcer by the inhibition of lot of things, especially the prostaglandin secretions. So if the prostaglandin secretion are inhibited in long term by the NSAID, then we know that prostaglandin helps in the repair and the alkalinity of the stomach. So the COX inhibitor, either it may be COX-1 or COX-2, both will decrease the availability of local prostaglandin, and this will increase the susceptibility to the stress and will cause stress bleeding. COX-1 is usually there in the large organs like stomach, kidney, heart. These are usually COX-1. And COX-2 are there in the inflammatory cells like lymphocyte, neutrophil, monocyte. So if we are having a drug which preferentially inhibit the COX-2, अगर वो केवल COX-2 को ज़्यादा inhibit करेगा, तो उससे हमें जो GI प्रॉब्लम है वो नहीं होगी, because it is preferentially inhibiting the cyclooxygenase pathway in the cells like neutrophils, lymphocyte. So it will cause less harm over the stomach. And if a drug is inhibiting the stomach, like COX-1 inhibitions, that will have more GI trouble. But the COX-2 inhibitors are having some cardiac side effects like celecoxib, ropicoxib, and because of this, the COX-2 inhibitors are usually banned in our country. We have drugs which acts basically on both the cyclooxygenase pathway, and the most important is the aspirin. If we take long duration aspirin, either entry coated or without entry coated, it will have effect on the COX inhibition, and it will decrease the prostaglandin activity and will cause the ulcers. Other causes of ulcers are less known, like age, as we have discussed, that as age advances, the chances of mucosal integrity is decreased. Any history of prolonged steroid intake, high dose of NSAID, multiple dose of NSAID, long duration of NSAID, anticoagulants taken with the NSAIDs, multi-organ failure, smoking, alcohol, any stress long term will cause bleeding, like curling ulcer. Curling ulcers are the ulcer of the stress. So in MCQ we will get that out of these the curling ulcer, how the curling ulcer occurs. So most common cause is burn. बर्न में कर्लिंग अल्सर्स के चांसेस ज़्यादा होते हैं. What we use to remember burn and curl. So in stress ulcer, curling ulcers are known to occur. And this is the schematic diagram how the NSAID will cause the ulceration. Like iron trapping. The acetylsalicylic acid or the aspirin is an acidic drug. And if acidic drug is there in an acidic milieu, अगर वहाँ पे stomach में milieu acidic है, तो this will not break and this will directly enter the cell because of its hydrophilic action. The acetylsalicylic acid or the aspirin will enter into the cell cytoplasm directly, but it will not, because of hydrophilicity, it will not go out of the cell and it gets trapped in the cytoplasm of the cell, and because of this it will cause disruption of the local activity in the cytoplasm, and this is the most common cause of aspirin toxicity, that is the iron trapping. Similarly, stasis, decreased secretion of mucus, bicarbonate, surface phospholipids. This will cause the break in the lining and will cause ulceration. Smoking, there is no direct correlation with the smoking and ulcer, but we know that smoking decreases the healing of any ulcer and hence it will decrease the healing in the stomach also. Genetic predisposition, we know that blood group O people are more prone for ulcerations, so there has to be some reason for this. So probably because of stress or other reasons, the O positive groups are more prone for ulcers and malignancy. These are the other causes of ulceration, but they are rare and therefore MCQ used only. Clinical features of APD. The most important is pain, but this pain is almost 90% not there in a patient of ulceration. So we have to have a very high clinical suspicions to have this pain. There are a lot of differential diagnoses for pain in the epigastrium, and we know by this that 90% of the patient of APD will not have the pain. So only 10% of the patient of APD will, when it come to you as a pain abdomen. And the pain of duodenal ulcer, we know that it occurs almost 2 to 3 hours post meal. खाना खाने के 2 घंटे के बाद पेन होता है, और अगर हम उसको कुछ खाना वाना खा लें तो उसका पेन कम हो जाता है. एंड गैस्ट्रिक अल्सर पेन वो खाना खाने से कभी कभी बढ़ भी जाता है. सो इट इज ए rough guide to differentiate whether it is a pain of gastric ulcer or the duodenal ulcer, and the pain localization characters are almost same in both the diseases. And if the character of pain changes, जैसे उसको 2-4 महीने से सिंपल पेन हो रहा है और suddenly the pain increases, or it is pain is in the central epigastrium and it is in the odd hours of the night, or there is another other symptoms compared to the pain, that means there is some other pathology which may be because of rupture of ulcer, any perforation, or if that ulcer has connected to nearby structure, like if it is connected to pancreas, it may have the pancreatic component of the pain. If it is perforation, it may have perforation peritonitis or hematemesis, and according to the etiology, we will have the sign and symptom. Initially, the patient will have nausea, vomiting, but it is more common in the gastric ulcers. We have to think of malignant transformation also, and if it is malignant transformation, the symptom may increase rapidly. Epigastric tendon would be there if we palpate the particular part of the hypochondrium or epigastric, and according to the disease progression, we will have symptoms as we have discussed right now. If there is pyloric obstructions, we can have sufficient spash by vigorously shaking the patient. If there is fluid collection in the stomach, we can hear a sound as we see over the respiratory part. We can hear over the abdominal also. Bleeding is there, but we have seen people consuming acid of acid antacid for prolonged duration of time. 20-20 साल से लोग एसिड खा रहे हैं, और अगर वो एसिड नहीं खाए तो उनको अच्छा नहीं लगता है, probably psychogenic or whatever. So these OTC drugs, cheap drugs, has increased these side effects significantly. पहले we had lot of patients coming with upper GI bleed because of perforation, ulcerations, lot of other side effects because of ulceration, but because of availability of good drugs, these side effects are seen less commonly. And we know that it will penetrate to the nearby structure, like the duodenal ulcer will penetrate toward the pancreas, leading to pancreatitis, and the gastric ulcer will penetrate near the hepatic loop and may cause hepatic inflammation. The differential diagnosis of peptic ulcer is non-peptic ulcer, that is the functional dysplasia. Functional dysplasia जिसमें कि functions abnormal है, but there is no organic cause. In peptic ulcer, we have discussed that there is an organic cause, that is ulceration. In functional dyspepsia, the patient would have a similar complaint, but there would not be a breach in the mucosal lining. Now, after confirming that we are dealing with the acid peptic disease, how to confirm the disease? Initially, we used to do the double contrast variant procedures. In this, we used to see the ulcers, but now with the availability of upper GI endoscopy at lot of places, this investigation is usually not done. Why? Because here we can just see that there is some breach in the connectivity. We cannot take a biopsy. We cannot take the enzyme, urease enzyme. We cannot do the H. pylori test. And if there is a bleeding ulcer is there, we cannot do the therapeutic treatment also. So this is an absolute test which is usually not done, or done if there is not availability of upper GI endoscopy. Endoscopy, as we have discussed, it will clearly distinguish whether we are dealing with a epigastric mass, ulcer, malignancy, obstruction, any other pathology, and simultaneously we can take the biopsy from the H. pylori. We can do the H. pylori test. We can do a biopsy for a malignant lesions, or we can do the therapeutic endoscopy also in a same procedure. And this is characteristics blood oozing which we can see in the endoscopy. To diagnose H. pylori, we do the invasive and non-invasive test. The invasive is rapid urease test, culture and histopathology, which we do by the biopsy which we have taken, And the non-invasive test is the breath urea test and serology. Out of this, the breath urea test is more confirmatory and easily done compared to the other test and has got more sensitivity compared to the stool and the serology test. And after confirming that we are dealing with a patient who is a H. pylori positive ulcer disease, or it is non-H. pylori related ulcer disease, or it may be because of other reasons, we have to give treatment. As we have discussed in the first few slides, how the cell wall had got lot of receptors for this HT hydrogen potassium ATPase enzyme, which is the main enzyme which increases the secretion of HCl in the canaliculum. So we will have the drugs which inhibits those cell wall receptors, and the initial first generation drugs were the antihistaminics or H2 receptor blockers. They are less used commonly because of less effectivity, but still they can decrease the ulcer incidence in almost 90% of patients if taken for 8 to 12 weeks of durations. The second is the proton pump inhibitors. There are a lot of drugs which are known as proton pump inhibitors like omeprazole, rabeprazole, pantoprazole, esomeprazole, and these are easily available at our places, and it is cheap and good drugs. If taken for long duration of time, almost 8 to 12 weeks, it will cause ulcer healing in maximum number of patients. If we feel that there is a large ulcer over the mucosa, we can give some mucosal protective agents like sucralfate, bismuth compounds, which will heal the crater of the lining of the blood vessels. They have got very less side effects and can be used for long duration of time. And we have seen people using these drugs since last 20 to 30 years without any particular side effect. And the proton pump inhibitors inhibit the sodium potassium, the hydrogen potassium ATPase enzyme irreversibly, and have got the action almost for 18 to 20 hours. That means it can be given usually once a day in the morning. If we give it is once a day, it will take care of the excess secretion for almost 24 hours. And if we see a clinical ulcer which is bleeding, we can give this as an injectable form twice daily also, or if the patient is admitted with hematemesis because of ulceration, we can give a prolonged infusion of proton pump for almost 48 to 72 hours initially. Then we can plan for twice daily and then once a day for almost 1 to 2 months for the effective healing of this ulceration. There are less and less drugs which causes interaction with these proton pumps, so it can be given easily with lot of drugs, and basically it should be given in the early morning so that it has got the maximum acid separation. Sucralfate, we have discussed that it binds on the crater of the ulcers and cause healing if taken for long duration of time. Bismuth, similarly, this also causes healing if taken for long duration of time. Prostaglandin analogs, we have discussed COX inhibitions. So if the prostaglandin analogs are taken, they will increase the local prostaglandin level over the mucosa and will cause healing. But it is a drug which is given for the as abortification also. So you should be 100% sure that there is no pregnancy. Otherwise, we may have lot of medical legal problems. If the ulcer is very large and the chances of H. pylori is there either by investigation, by the clinical feature, or by the endoscopic evidence, we should try to eradicate the H. pylori, because if we are not able to eradicate the H. pylori, it may cause lot of disease as we have discussed right now. So in the education of H. pylori induced peptic ulceration, we had got lot of combination of drugs, and in the combination, the drugs are having, one is either amoxicillin, one is clarithromycin, and one is pantoprazole or any proton pump inhibitors. They are given in combinations and usually given twice a day. There are three, four combinations which are available in the market, and basically they all had these three combinations and are given for prolonged times, that is almost 14 days and twice daily, one daily. एक गोली सुबह एक गोली शाम को at least for 14 days to cause to have eradication of H. pylori. Normally we get the eradication of H. pylori if the patient is taking these drugs religiously, and we expect that almost 90% of patients are eradicated by these drugs, and then we can give the proton pump inhibition for the rest amount of time. And if we feel that the ulcer is large, then we can give, well, we can add the